My question is, what is going on here? Peter, you talked about three things. I think the way my mind works after BU law is very methodical. What are the three things or two things that are of immediate concern to these business owners that they have to think about in the next 3 or 4 months?
Well, I think I mentioned a couple of them earlier. The notices that have to go out in the near term and are going out in the near term. But the other thing that is to do the analysis to see if you are close to the 50 full-time employee limit. Try to do the analysis now in terms of whether or not you're going to fit within the large employer category under the ACA, and that means taking a look at those things that I mentioned before. Your full-time employees, doing the calculation with respect to the less than full-time employees, and doing the math to come up with a total combined full-time and non-full-time cohort of employees to see whether you reach the 50, and also examining the coverage that you're offering in terms of the affordability. The 9.5% of the wages for compared to the premium burden of the self-only coverage, and also the minimum the actuarial value of the coverage that you're offering. There are a couple of resources available for you. If you go to the Kaiser Family Foundation website, kff.org, there is a subsidy calculator. You can plug in a individual's information with respect to age and whether they're children and salary and whether they smoke or not, and it will give you what their anticipated subsidy may or may not be, depending upon where they fall within the 100 to 400 of federal poverty level range. It's interesting to note that, as Patrick had mentioned earlier, that that calculation will give you what the subsidy might be, but it doesn't necessarily tell you what the overall burden on that employee is going to be of the coverage. The out-of-pocket maximum is $6,350 for self-only coverage. And if you add, and that's deductibles and co-payments and co-insurance, and you have to think about whether or not the coverage that you're offering is going to be affordable in a global sense to the employee, not just with respect to the premium, but what are the other things that he or she's going to have to pay for. So I think even though there is an opportunity here to not have to address this immediately because of the delay in the shared responsibility payment obligation, I don't think that means you should ignore the issue of first determining whether or not the ACA applies to me, and secondly, evaluating the offerings that you're making available to your employees.
Gene, in terms of the notification, the connector may be of some assistance, that notification that's due October 1.
Yes, so when I said a few minutes ago that we would like to be a resource to the employer community, that was one of the things that was prominently in my head. So yes, we are going to actually, we have a newly assembled the Employer Advisory Council. Some of our members are here with us today. So we are, through that council, we are actually processing some designed templates just to make sure that they are easy to use. They're going to be delivering the message without confusing the hell out of everybody. So this is a process that we're trying to go through because we think that that's the least that we could do.
Thank you, Jean. And panelists are free to jump in at any time if they want to add on to anything that's been said. Jack, there's taxes and fees, obviously, changes in costs that businesses will face. Are there any strategies that business owners or human resource or benefit managers should be thinking about using to lower cost or optimizing benefits? Anything specific?
Yeah, again, I'm the messenger of news that probably everyone is is familiar with, but there are new taxes and fees, and the indications from the market are that the new taxes and fees will be about 3 to 4% additional or incremental costs that are infused in the premium. And then also, as it relates to cost, you have traditional underlying medical inflation, which includes unit cost and severity. And with the new taxes and those underlying traditional components, you come up with a pricing trend. And pricing for 2014, we haven't obviously seen the small group pricing, but we have seen some of our larger insured customers, some of their renewals. And the pricing trends, these are fully experienced, fully credible groups, are running in the high 5s to low 6s. So I guess that's encouraging. I'm not certain if it's a harbinger for the small group market, but that's what we've seen from some of our early renewals in the marketplace from a pricing trend perspective that's applied in the formula. Again, fully experienced, very large groups. So I guess that's pretty good news, I guess. You know, as it relates to structuring strategies, there are many different types of strategies that an employer can look at. I guess each employer is unique and competes within an industry for customers. So I guess we would recommend looking at benchmarking, looking at what other employers within your industry are doing, because attracting and retaining employees becomes very important. And also the price point on the products which are commonly offered within your industry also become important as just a point of information as you make benefit decisions. And then from there, culturally, what type of culture do you have as an employer? And what type of underlying benefits meet that culture and meet how you want to treat your employees and their families? And then what type of contribution approach best fits your culture, your competitive environment, and how you want to drive your business? It's all about business success. Let's not overlook the fact that what we're doing here is talking about how to empower businesses to grow their business and grow the economy. And that's our role as an advisor, to position our employer customers in that way so that they drive the success of their business. And their benefit purchasing should be very much in line with their business strategy. And so we would look at different types of contribution approaches. In particular, the defined contribution approach is becoming more and more formalized, and technology's helping with that. Ben admin technology's helping with that. And then structuring a plan so that, as Gene indicated, there's a benchmark plan or an indexed plan that you target your corporate contribution or employer contribution on, ensuring that it meets minimum value and affordability. And I think, one of the panelists was mentioning the importance of preparedness for 2015. It is very important to prepare for 15. Do the full-time employee count. Look at the affordability testing. Understand that as you head into 2015 so that you're structuring and thinking and preparing and planning and thinking about introducing benefits in 14 and contribution approaches in 14 that sets you up for 15, 16, 17, and beyond. But I guess structuring the benefit design using an index approach so that you're stabilizing future cost increase from an employer contribution perspective, and then giving your employees choice of benefits, really an array of medical programs, dental, life and disability are typically what we're seeing across all businesses, small and large, and ensuring that, again, you're structuring the program, the price points on the program, and the corporate contributions so that you're in line with the business strategy for success.
Gene?
So if I may, just wanted to make a general comment on pricing because, as Peter mentioned, which I completely agree, there is a market-wide premium watch at this point. The market is sort of in anticipation of what 2014 pricing is going to look like. I don't have any sort of inside view, so we're all waiting. I'm sort of speaking to the small and non-group market, the merged market right now. So we're all anticipating sort of the upcoming results of the DOI rate review, which is scheduled to complete around August 15. So watch the paper, there will be probably lots of stories around that. So you probably recall that maybe a couple of months ago, maybe a little bit further than that, nationally there was a pretty heated discussion in terms of anticipated premium shock across the nation. And then there was quite a bit of logic behind it, because if you look beyond Massachusetts, many of the other states, in fact all of them, are anticipating the inflow of newly insured. A lot of them had pent-up demand because they did not have access to regular health care, so there was a lot of sort of demand for care that is going to really shoot up the market, and then obviously the cost needs to be borne by the rest of the market, so the premium inflation was anticipated to be very significant based on pretty sound actuarial analysis. But I guess empirically, if you look at a few of the states that came out with the rate results, overall it's been pretty positive. Several states were sort of pleasantly surprised that the rates did not go certainly as high as anyone anticipated, but in some states it was actually quite a bit lower than historical sort of levels. So I guess that the point is there's a lot going on here, because some of it is overall inflation, some of it is redistribution, and then some of it, insurance companies, they need to be competitive as well. So they need to take a look at where their price point is today, where their price point is going to be if they didn't do anything, and what they could do to gain some of that advantage. So I would just encourage the market to look at what your rate's going to be, and also look around and look at other options, because there were many moving pieces in the market, and this is the time to really fully, as Jack mentioned, to fully look at your options and look the best fit for you.
Patrick, any response to that, or I can ask you a question? The not-for-profit insurers have had a lot of a list of their own problems with the ACA, the taxes, the fees that you alluded to earlier. What support and options can you give to employers as insurance companies? The employers, I think, are going to be faced with a lot of questions from their workers. They're looking to the bosses for expert advice, and how can insurers help?
Well, in terms of some of the issues with the ACA, I think Secretary Shor actually, talked about that pretty extensively, and some of the other speakers have alluded to it. Obviously there is a lot changing. I think those of us who are close to health insurance or to health care, looking at this a year or two ago, where people were saying, we already have health care reform in Massachusetts, this won't be a big deal. We were saying, it may be a bigger deal, but I think even at that, I think it wasn't until really the last several months where we've started to get the detailed rules from different regulatory agencies, particularly at the federal level, about how all this is work, that we've really come to appreciate, how big of a change it is. Somebody had asked me recently, was Chapter 58 like this? And I think this is really bigger, I think, because there are probably more pieces to the ACA, and to some extent we've had to kind of unwind some of what was built as a result of Chapter 58 and recast it for the ACA. That having been said, I think at this point most of the rules are pretty much in place. We know what we're going to be dealing with moving forward. As Jean talked about, I think in other states you've got a whole different dynamic. I'm not sure which is better or which is worse, but there are some where some other states, these concepts that we're dealing with aren't anything familiar, aren't anything that have been around in the past at all. In terms of what we can do to support our customers, I think we need to do what we should have always been doing, but it becomes really more crucial now in terms of understanding how these changes are going to impact what's available, what types of plans customers will have. There's been, I think, discussion from some of the previous speakers, including Jean's comments just now, about the rates, and Jack had talked about this too, about the different components that are going into it. What would trend be without the ACA? You've got this issue of the ACA possibly, bumping things up a little bit more due to some of the taxes and fees and other changes. And then you have, some of the issues around the rating factors and kind of where is that going to land? The customers could have a range of experiences up or down. So I think we really need to make sure that we provide support to customers so that they understand what's happening as they move into 2014. Where their rates are going to fall, different options that may be available to them. There's been a lot of speculation. I don't think this is any big secret that some customers may be looking to possibly cut their plan year short and buy a new plan at the first of the year if they think they're getting a good deal in 14, or before the end of 2013 if they think they're doing better under the old system to try to delay moving into the new system for a year. So we're going to need to provide some support around those types of issues in terms of what can be done there. We're going to need to provide some support around understanding options around the employer shared responsibility piece as well. Moving forward, employers may be looking to expand eligibility. They may be looking to add new plan options to accommodate some of the requirements there. So we're going to need to, again, work with employers there. I brought up earlier the out-of-pocket maximum piece. Peter had talked about that too a little bit. That's another one where we're going to have to make sure that employers and other customers understand what's happening in that space as well. So I think it's pretty much, that's pretty much what we've always needed to do for our customers, but because of all these changes, it becomes even more crucial. In terms of, employers dealing with their employees, I think, again, we're going to need to provide the employers support on that piece as well, in helping employees to understand what's changing and what their options may be. We may see some groups, for example, adding additional plans in order to comply with the employer shared responsibility piece. There's going to be a need for help employees understand different options in terms of different cost sharing levels that may be available, for example. So, in a way, it's kind of the kinds of things we've always done, but I think because so much is changing, particularly in the merge market, I think it becomes more crucial at this point than ever before to really stay on top of that.
Peter.
Could I interject? Could I interject sort of a question? I want to throw it up to the other members of the panel. One of the sort of broader gauged questions I have on almost a public policy level is what are the informed speculations of people who know more about this than I, as to what the rate of insurance take-up is going to be among younger, healthier folks. I mean, one of the issues I see with respect to the overall success of the ACA is whether or not you're going to get everybody into the insurance pool, and the question will be whether or not young people are going to be wanting to pay the insurance premiums or pay the penalty for not having insurance. Have there been any studies made that anyone is aware of that talks about what the likelihood of that cohort of young, healthy people taking up insurance over the next couple of years would be?
In Massachusetts, we have a very high rate of insured. I think we're 98%, maybe slightly north or slightly south of that. And so many of the young folks are in. And they're either covered through the policy they've purchased themselves, covered through a student health plan. And there's a lot happening in the student health plan market. There's improvement in benefits. If anyone has a college student in the room that's going to a local college or university, they're typically offered coverage through mom or dad if they have coverage, and/or offered coverage through the school so that they can be covered by a high-quality health plan. So, given that there's such a high propensity of folks that are covered, and given the coverage options that are available within colleges and universities, and other opportunities for there to be subsidized coverages through CHIP and things like that, in Massachusetts, likely not as big an issue as it would be in, say, some other state.
I was going to kind of make that point too, that to go back to what Gene had said earlier, and Secretary Shor talked about this earlier in his comments, that because of some of the things that we've already put into place in Massachusetts, our rate of insurance coverage among young people is probably higher than it is in a lot of other states to begin with. Does it change much from that? I don't know. I haven't really seen any studies. I think the hope is that some of these things will continue to increase the rate of insurance, but I don't know that there's a concrete number there. One thing that I do believe is happening is the connector has had the young adult plans in the past. Those are being replaced by the new catastrophic plans. How much of a transition there is between those two, or if we'll see some of those young adults move into other plans, I think remains to be seen. But there's some changes happening there that may have an impact one way or another.
Yeah, so I would echo that. You don't have a stable, affordable health insurance market without the young and healthy. So I think the ACA is very much aware of that, and in its design, you can see a number of elements specifically designed to address that. The catastrophic plan option that is available, which is not exactly the same as young adult plan in a number of important ways, but the intent has a lot of commonalities in there. The catastrophic plan actually does not fit the metallic tier. The actuarial value is actually quite a bit below 60%, but the only people who are eligible for it is is the less than 30 or otherwise not subject to the individual mandate. So it certainly is targeting the young population. So I would say that, you know, besides what Jack mentioned, and there are the history in Massachusetts of coverage for this population through, particularly through the requirement for the student health insurance, is actually a very important foundation that sort of helps that population stay in the insurance pool. So there is a starting point. So we are feeling pretty confident that this state has a pretty good handle on this population. Now, I don't know the specific status that's in my head, but for example, there was a very helpful Blue Cross Blue Shield Foundation research that was published last year about sort of, what's the title of that, Audrey? The remaining uninsured, covering the remaining uninsured. It has very detailed numbers in terms of not so much the young adults, but who are the remaining uninsured. And then, so the young adults are not the prominent population. It's a lot of them are the very low income. A lot of them are the sort of the transit population. So from that respect, it does suggest that the young and healthy is a key participant, a sort of a solid participant of our insurance market, which is good news.
Yeah, we of course actually increased employer coverage after the 2006 reform, and while ACA does give, I think, some opportunities for people to drop out, I think the general feeling is that employers are going to continue to do, for whatever reason in Massachusetts, this is the question I get asked more than any other question when I travel around the country is amongst my peers, is why do people not just pay the $295, or why had they not just paid the $295 and dropped insurance? And for whatever reason, cultural, competitive, it's a inexpensive and effective way to compensate employees. All of those reasons, Massachusetts employers have stepped up to the plate and offered insurance. And you know, I think everybody thinks it'll continue despite the opportunities in ACA. Peter, I just did want to get to one question and try to anticipate some of the questions you might have, but it's been talked about a little bit here, but what about that 50? How do you count to 50, and what happens if you go above it or below it, and part-time and all of that?
How do you count to 50? That sounds like a pretty easy calculation. You're talking to a guy who was going to be an architect until he realized calculus was involved. But yeah, basically to simplify, and I can't emphasize that enough, to simplify, you have to have your advisors help you through this calculation on a case-by-case basis. But to simplify, basically to get to 50 employees, you take your full-time employees, which are defined as 30 hours per week, and they count towards the 50, and then you take the people who are working less than 30 hours a week, and you add up all of their hours on a 30-hour a week or 120-hour a month basis, and they get counted. You know, you do that math, and you know, 7 or you know 8 3/4-time folk will be 6 full-time people, and you add that to the full-time people. Now there are special rules, of course. There are special rules for people like seasonal employees, generally folks who work less than 3 months of the year, and the nature of whose work is tied to a particular season, like Christmas time workers or summertime workers. Again, to simplify, if you are over 50 for, I believe it's less than 120 days during the course of a year, and every person who brings you over the 50 employee level is a seasonal employee, then you are not a large employer and you don't meet the 50. If you are an educational institution, for example, there are special rules that talk about essentially faculty and people who may be on 9-month contracts. Basically, those folks, if their time not on active duty, if you will, at the educational institution fits within certain parameters, they're going to be allocated, if you will, over the course of the entire year. And if they're full-time employees during the school year, they're going to be counted as full-time employees during the course of the entire calendar year. So, that's basically the calculation you have to make. Now, you may be tempted, I'm sure people are tempted to say, well, what I'll just do is I'll just disaggregate my business and break it up into 3 30-employee chunks. And they have anticipated that, and you will not get away with that. They will use the affiliated service and control group rules in the tax code to say that those, if you try to do that, all those smaller entities will be considered to be one employer. So that's not going to fly. Again, the calculation of how to get to 50 is relatively simple. The calculation of calculating the shared responsibility payment, if you do find that you have to do that, is much more complicated, and it is in fact mind-numbingly dense, and I'm hoping for relief from the feds in the coming months on that. Another thing that you might be tempted to do, you're all good people, you wouldn't do this, it would be to find that you are a large employer in the ACA and find that one of your employees, despite your best efforts, is getting subsidized exchange coverage. You might be, and therefore triggering one of the 2 flavors of shared responsibility coverage. You might be tempted to terminate that person. There are discrimination rules, anti-discrimination rules in the ACA that are specifically designed to prevent you from doing that. So I think sort of all of the obvious dodges, if you will, have been covered with respect to whether or not you are going to be a large employer for purposes of the ACA. But for those of you who are, close to that number, it's important to do the calculation. Now, the calculation is going to be based in most years on a full year calculation. For 2014, you get to count full-time employees over any 6-month period in 2013 for purposes of making that calculation. Nevertheless, going forward, you should be making that calculation on a full year basis. And basically, as I said, it's just taking the full-time folks and then adding up the non-full-time hours, dividing by 30 hours per week, and going forward.
Okay, anybody have any comments before we go to the audience for questions? And we really have a hard time? Nothing further? Okay. We're going to go to questions from the audience at this time. I'm the executive director of the National Federation of Independent Business, which is a small business advocacy group. Just to let you know, NFIB was a party plaintiff in the Supreme Court case challenging the constitutionality of federal health care reform that was decided against us on a 5-4 vote. I say that so that you know where I personally come from and where my organization comes from. And there are plenty of issues that I have with state and federal health care reform, specifically around the costs. But this morning, this panel is here to try to help you understand the implementation of the ACA in Massachusetts specifically, where it's different from any other state in the nation. And I'd ask, therefore, that your questions focus on those, really practical business operational issues rather than political issues. I'll stay afterwards and talk to anybody who needs to vent about the situation in Washington, in Congress, and in the legislature in Massachusetts. But to that extent, your questions, if they have a general application of a practical business application, I think more people in the room will benefit. So with that, are there any questions? Yes.
Thank you. Good morning. I'm Kim Sappington. I'm the director of the Local Workforce Investment Board. And my question really is around, we're seeing a trend, especially in Central Mass, of employers in manufacturing hiring specifically through temp agencies. And I wondered how this reform is going to affect those employers, because they generally maintain they are the employer of record for these folks. Some are hired for particular projects, which may be short-term. Some may be, working for the temp agency for a number of years before they're brought on permanently. So what do you anticipate the impact is for both those employees
Peter.
I assume that's directed to me. They're going to have to do the same calculations as anyone else. The temps are employees of the temp agency, and they're going to have some very complicated calculations to be made with respect to how long people are there and how long they're working. There's no exception to my knowledge of temp agencies from coverage of the ACA.
If I could,
Yeah,
I think that
Jack.
particular population in general may be underserved because of cultural barriers. And so in dialogue with those temporary staffing agencies, I think it becomes important to have multilingual communications and to have folks who may speak their language become part of the process to educate that workforce in purchasing health care and the vehicles that are available for them to do it.
Hi, I just wondered if there's any anticipation, this is probably just a legal expert, as to whether or not the federal government will just simply eliminate or reduce the under 50 exemption down the road.
I don't see that happening. I think what might happen is a redefinition of full-time to 40 hours a week rather than 30. There are lots of different thresholds in the ACA in terms of whether or not you're a large or a small employer. There's some rules apply to people over 200 employees. Some rules apply to folks over 100 employees. A 50-employee rule is part of a complex regulatory scheme that was developed in a highly political process. And sometimes when you're elbows deep in the sausage, you're going to pull up some interesting items. And maybe the 50 is a product of that process and without any particular public policy rationale behind it. But I don't see that necessarily changing.
I have this question. One of the provisions in the ACA is that the non-discrimination provisions that apply to health care that is self-funded by the employer are to be extended to insured healthcare insurance. One of the thoughts that I had is that the ACA provisions for employer responsibility apply to the larger applicable employers, 50 or more. Has anybody heard whether or not there's any speculation as to whether or not those non-discrimination provisions would require an offer of coverage to folks that work 30 hours or more as opposed to 35? Because that's the big difference between mass healthcare reform definition of full-time employee versus the ACA. So I was thinking that's one way they might try to get to companies under 50 employees is by requiring the issuers to get the employers to offer the coverage to 30 or more. But any thoughts or comments on that?
I have not heard anything to that effect myself.
No, I haven't heard anything on that one either. That was one where I think they issued some guidance that basically said, we'll let you know what to do, and until then, you don't have to do anything, and it's been just left hanging out there since then.
Hi, I'm an owner of a business, and we were proud to offer health insurance to our employees as of July 1. My question sort of extends from, Peter, your comments regarding being a good employer, best intentions, although the question is directed to anyone at the panel. Best intentions, we feel we meet criteria regarding the affordability as well as minimum value, but an employee chooses to go to the connector, or I guess that's their option, and are there any gaps or fail-safes to prevent an employee from purchasing outside of a group-offered plan? Because I'm really worried about sort of the protection as an employer. I've done my best to offer a plan that meets the criteria, but an employee goes out to make a purchase individually, and that now triggers me for, and exposes my liability and risk. just sort of trying to understand, you know, where's the sort of protection?
Yeah, this is a major change from Massachusetts where they couldn't do that, so.
Yeah, I think that this is another situation where you need to look at the overall costs of the coverage that you're offering to your employees, including the out-of-pocket maximums, because they have to make their own decision economically based upon their own personal and family circumstances to whether to take that up. And I think the best advice I would give you would be to have those conversations with people. I mean, the system is designed to make it a better deal, make it clear whether it's a better deal to get subsidized coverage through the exchange or employer-sponsored coverage. And so maybe it's a matter to some degree of a frank conversation with the employee about, if you do this, think about what level of subsidy you're going to get versus the plan, the familiar plan that you have right now, and whether or not it's worth your trouble to do that. And look what you're doing to me.
The response is that they can still get the subsidy. There's nothing from preventing them from getting the subsidy.
If the numbers work out for them, yeah.
So I do want to really emphasize this point, because just looking at the numbers is critical, because the subsidies is a function of person's income. So there is an affordability schedule that is a sliding scale. So for an employee that is not the lowest income, the subsidy is likely not going to be as generous as the employer contribution. In fact, the gap could be pretty material. So the likelihood of that, I would say, is not extreme. Although I would acknowledge there are certain other aspects, because, for example, the merged market is subject to certain benefit requirement. There are certain benefits that could be offered in that particular market, but is not sort of broadly required in outside of that particular market. So there could be certain incidents where an employee would seek a particular opportunity. I think this is where you are right. There are no particular mechanism to put the stop to that, but then a dialogue would be very important.
Hi, my name is Melody Robleski. I'm a revenue consultant for medical practices. And my question is derived from the results of the risk management assessment. After that occurs, and then we get to the level of the individual, at that point, is there anything in process where if you do have a healthy individual, 30s, 40s, 50s, and on, is there any sort of credit for that individual after that group number occurs?
I'm sorry, I'm not sure if I quite understand the question.
Okay, so this is the risk adjustment occurs, and so you have that variety from the young all the way through to have that level of the amount that they need to pay. And now you have somebody in their 30s, 40s, or 50s that it's a very healthy individual. Are there in place any strategies or ways that that individual could get an additional credit based on their health?
In terms of the rating, I don't believe they are. Now, the risk adjustment program, as I understand it, is going to be kind of looking at the rates, and Gene, you may know more about how this works than I do, is going to be looking at kind of the rates retrospectively, although the idea is that insurers are going to kind of have to try to figure out where they think that's going to land in terms of pricing up front. In terms of the rates that are going to go out to the groups, that's pretty much just going to be age is going to be the big rating factor remaining moving forward. But the groups are going to get a rate, again based on their membership, and I don't think there's any adjustment beyond that. I'm not sure if that's answering your question, but that's.
That does.
Yeah. Okay.
And I'm a healthcare writer. I'm really interested in the idea of whether there are any innovations on the horizon that might actually help bring costs down. And I was wondering what the experience with the narrow networks has been, and whether the ACA leaves room for innovations such as direct primary care or centers of excellence where people can send patients with very high cost surgeries to specialized centers where they can get better care at lower cost.
So, great question. Innovations are happening on a daily basis as it relates to health plans and as it relates to other health IT companies that are being infused into health plan delivery. narrow networks, select networks, particularly in Central Mass, where I guess they were born, right? Fallon has the direct care, and that's been a very favorable product in the marketplace from a pricing perspective. Other carriers, virtually all but one major carrier in the state, have that narrow network approach. And recently, the AGO published a report in April. I don't know if anyone's seen the report. If you haven't, I would highly recommend that read. It's about 60 pages deep, but it does talk about the pricing and the morbidity, how the risk profiles are different within the different types of products. And narrow network and tiered network products, those are relatively new in the marketplace. They're in the second, third, and fourth generation, have been generating greater consumerism and engagement in the cost of care and how care is purchased as a consumer within the network. So I think there's big opportunity from a network innovation perspective. And then you layer on product design on top of that, and you can create that incremental level of consumerism and cost-sharing value where you're really empowering the consumer to make a choice on what type of product they want, what type of network best fits their needs, and what type of benefit design and cost-share values work. Then you have HSA-compliant products, and you have HRA compliant products which give financial vehicles for consumers to apply to their medical programs and fund the cost of certain services. And from an HSA perspective, that's pre-tax dollars that get carried forward with the employee to pay for future expenses. So a lot of innovation there, a lot of innovation around transparency tools and out-of-pocket calculators that are real and plugged into the benefit design so that if you're going in for a service, you can plug in the provider and plug in the type of service you're going to get. You'll see what that expense would look like after your benefits and deductibles have been applied on a year-to-date basis. So from a transparency and a view on real-time basis, that technology is catching up and those innovations will be big. I think if you look at the plan designs as we head into 2014, there will be much more cost sharing. And so the employees and consumers will need to pay attention to those changes in benefit design. Certainly premium would be modified with the cost share, but again, the cost share would be picked up by the employee.
I think in any discussion about healthcare that's taken place over the past several years, I mean, cost has always been the big issue. And I think it's something that no one's to date has been able to entirely get a handle on. I think that the early healthcare reform legislation that we had in Massachusetts did attempt to address it in kind of a piecemeal manner to kind of pick at it a little bit. Chapter 224, the last one, I think really made much more of an effort to try to tackle that head on. Although I think a lot of the pieces of that around cost control really haven't fully come to fruition yet. There'll be something that I think we'll be seeing playing out more over the next year or two. The ACA, I think, is kind of more on the level of the early mass healthcare reform legislation, in that it doesn't, as people have said earlier, in terms of, like, for example, the rating, it kind of redistributes things. I don't know that it really has a lot in it that takes a big bite out of cost. So I think this is really still, an open issue that people are working on. The limited network products, certainly have been one approach to that. As Jack talked about, I think they have been fairly successful. We're seeing the tiered products becoming more common as well. That is one way to go, but I think there's still a lot that needs to be done on kind of the issue of underlying cost. And I don't know that I have a good answer to that at this point. Jack also talked about the transparency provisions. There are some pieces in Chapter 224 around that I think are going to push insurers in the direction of making a lot more information available about costs and about pricing to members moving forward. I think this is particularly important as we move towards products that do have higher cost sharing and deductibles and whatnot, that from the point of view of a member that they can get a sense of what these costs are going in, how different providers compare to each other, what different options are. So that is another piece that I think over the next year or so, as a result of a couple of time deadlines that are in Chapter 224, you're going to see insurers moving more in that direction and making more information of that type available.
I would just sort of add to that. So first off, I just wanted to thank you for that question, because this is really a very important one, because as we think about the reform, especially the insurance market reform, we talk about setting the rules and trying to structure a more efficient market, but ultimately that does need to translate to downstream effects. because ultimately the cost needs to come out of somewhere. So it needs to come out of the delivery system and how care is structured. And from my personal perspective, serving both on the insurance market side, which is the Affordable Care Act and Health Connector, and also on the Health Policy Commission, really gives me that intersection and hopefully continuity view, which I think is very valuable. In terms of the narrower network model, if you take a look at the Commonwealth Care program that we have in the Health Connector, which is a little bit of a sort of confined environment, but it's an experimental environment. We have about a third of the population in narrower network plans, so it's not a selective few. It's actually a pretty stable population, and that material presence has a very strong impact on the cost. So as Secretary Shor mentioned, we were able to maintain annual cost trend over a 7 period at 1%. In particular, it was actually a 12% decrease over the past 2 years. That was directly attributable to the presence of narrower network plans, and member satisfaction remains extremely high. So there is some evidence that this could work if it's done right, if there is sufficient transparency out there that people actually know there is nothing scary about narrower network. It can work, and then there's a lot of oversight. So then again, there is nothing sort of great about narrower network unless it can actually reduce costs. So what we want to have is members starting to feel comfortable using more lower cost community facilities, knowing that they're not going into some kind of unknown sort of risk. So until consumers start to be engaged in that conscious decision, we're just sort of segmenting the population. So I think it's a key issue. It requires a lot of work, a lot of collaboration by the market for something like this to truly take off.
Yeah, and part of the response of the provider networks is to start focusing on population health rather than individual health, and obviously the reimbursement regime is moving away from fee-for-service towards a more global budgeting, and I think you're going to find in response to all of these pressures, as one part of the healthcare balloon gets squeezed, the other part will poop out, and then that'll get squeezed again. The provider networks are going to get larger. They're going to position themselves to deal with larger populations. We already are pretty far down that path, I think, here in Massachusetts with the stewards and the partners and folks like that. And hopefully one of these days we'll see a return on investment in electronic medical records. If we could get the various systems to talk to each other, that would be a lovely thing. And steps are being taken to make that happen. But I think you are already seeing sort of parallel developments, if you will, on the provider side as well as on the payer side to deal with both the access and the cost issues in an effort to be more efficient and more data-driven in their benefit and provider network designs.
Questions? Peter?
We're right there at 10:17. I think that's good.
Okay. Thank you very much. Thank you for coming.
Terrific job by our panel. I just had a couple comments before you head out. Let's thank them all. I have a gift for each one of them, which is one of those Worcester books. And I want to just say a few more thank yous as we close. First, to our presenting sponsor, Fallon Community Health Plan, for all they did to make this event happen. To Benefit Development Group and their support in making this event happen. To our media partners, WTAG. And special thanks to Coral Seafood, Curry Printing, Elevation Exhibits, and Ron Boulay Photography. And Revelation Productions, by the way, the folks who are in charge of the sound, all these curtains, all this staging. We had a videographer scheduled on our own to be here this morning. At the last second, he couldn't make it. And Revelation came up with a staffer and set up their cameras. So just terrific support from them making this a first-class event. Thank you so much. So again, that's it for this morning. Please feel free to stay in network. Bill will be having a group of those who want to rant about Obamacare up here in the front. There is a dinner here at 6 o'clock, so they have to be out by 4. But anyways, thank you again for coming, and I hope you got great value out of this morning.